process, literature, and then a little bit about the cost of medicine. So our patient who presented was a 75-year-old female. She came in with about 24 hours of worsening abdominal pain and distension. She'd had some nausea but no emesis, some subjective fevers, and described her pain as being epigastric and then becoming somewhat more diffuse, but still seemed to be worse in the upper abdomen. Other pertinent notes from her history, she relayed to us that she said she had no history of reflux or ulcer disease. There was some discrepancy with the information in Epic, but she wasn't on anything at that time, certainly for reflux. She had no history of a GI bleed and reported no blood in her stools or otherwise at this time. She'd had no changes in her bowel habits, hadn't had any weight loss. Her last colonoscopy had been 5 years previous, and according to her, was relatively normal. She had some problems with chronic constipation and had taken a variance of Miralax and stool softeners over the time before that. She also had a history of COPD and reported that she became short of breath after walking only 10 feet. Any other pertinent things in her history, again, she was 75 with sort of a long list of medical problems, but pertinent problems, again, COPD, some chronic kidney disease. Again, GERD was relayed in Epic, but as I stated before, she did not indicate that she was having any real problems at the time with reflux and wasn't on anything for that. She was on aspirin and she was on meloxicam for her osteoarthritis. Other pertinent that she did not use tobacco at this time, but again did have COPD, was not on any home oxygen. Her physical exam was fairly impressive as far as her abdominal exam. Otherwise, she was afebrile, she was hemodynamically stable, she was able to converse with us appropriately, but her abdomen was soft, distended, and she had focal peritonitis in the upper abdomen. Her labs, again, were fairly unremarkable. Despite her abdominal exam, she had a white count of 9.8. Her hematocrit was low, 22.7. She'd had one from 2 months previous to an orthopedic procedure that was 24.1, so it was a little bit lower, but some chronic anemia, and again, some chronic kidney disease with a creatinine of 1.1. Her initial CT scan, she initially presented at East and then was transferred down here because of her exam and her findings. So as we go through, you see some dots of free air. Again, particularly up around the duodenum, kind of between the gallbladder, some dots of free air, certainly concerning, and some fluid, a little bit of inflammation and stranding. No real pathology in the lower abdomen other than stool burden. And again, the same thing here, some free peritoneal air, not a significant amount of fluid, but certainly some. Gallbladder appears to be distended. So you see a little bit up here over the liver, and she had some sort of around her duodenum as well. So these, for the medical students, the black dots that don't appear to be within a lumen, that otherwise should not be there. Not a lot of free air, no. But certainly she did have some. So the concern at this time was that she had a perforated ulcer. Given her exam again with her tenderness in the upper abdomen and these sort of tiny locules of free air around the area.
Is that all free air? Isn't that free air here, or is that?
This right here is, there's a lot of that's actually within a lumen. But you do have some right there, The radiologist felt that this was likely either a perforated colon, her cecum, her colon you kind of see up in the same area, or perforated ulcer disease. After our evaluation of the patient, we felt that this was likely a perforated ulcer, given her presentation, where her abdominal pain, discomfort was, the air around her duodenum in particular, and did not think this was likely perforated colon. Given her history of COPD, her other medical problems. This had been going on for now, at the time she was transferred here, about 2 days or so. The decision was made to keep the patient NPO. We put her on IV antibiotics. We gave her Zosyn, started her on IV Protonics, and planned to watch her clinically to see how she progressed. So throughout that night, she was checked on several times, and actually her exam started to improve somewhat. She did have a mild temperature up to 100.6. The following morning, our white count had increased a little bit to 11.5 from 9. But she, that day, and quite frankly every day beyond that, said, I feel a little bit better, and her abdominal exam did objectively improve some. So the decision was made the second day that we would go ahead and repeat the CT scan. She was given PO contrast, had a little bit of nausea with this, but was able to tolerate it. On this scan, we see increased distension of her stomach that was not quite so present before.
That's contrasted CT.
Yes, sir. So massive distension that we didn't see before. There's increase certainly in the fluid in the area, some inflammatory stranding. She continues to have free air.
Going out for air.
So you can see some here. And then this up here is her stomach that has become significantly distended in the course of the 24 hours. And then her colon right here. So she's got, again, just this continued air sort of around this area.
How is she doing clinically now?
She was improving. She felt like she was improving. Her exam was improving, and she had focal peritonitis at presentation that, again, seemed
Well,
to
because
be getting a little bit
we
less
made the
each
point
time.
to the medical students here 2 weeks ago about peritonitis is pretty much usually an indication to operate on somebody, and you described her as having peritonitis in the upper abdomen, which really she just had rebound, I would imagine. But so we're treating somebody very conservatively or very liberally, right? Depending
Yes.
on how you look at that.
Yes.
Okay.
But fortunately, she was improving. Thankfully, we had consistency among the examiners as well, and so it was a fairly reliable assessment that she was improving, which is always important for the student. So, you know, the same person, if you're able to see someone...
Well, and the
you're
other
able to
important point, again, for them to realize is that you didn't describe somebody who was septic.
No.
She's anemic, but she's not septic, at least she's leukocytosis, that
Right.
sort of thing. She's not febrile.
She was not febrile. She was hemodynamically stable. She was able to talk with us.
Yeah, you said she's tachypnic, but she's not particularly tachycardic.
A little bit tachypnic, more so from pain. I mean, she certainly endorsed pain, and was very, very tender, like I said. I mean, she had focal peritonitis, but she was relatively stable otherwise. And again, throughout the night, even over the course of several hours, each time we saw her was a little bit improved each time. So the plan at this point, again, there was some more free fluid in the upper abdomen that wasn't there before. Her stomach was certainly more distended than she'd been before, but she again continued to improve. So we stayed the course. She remained in PO. Her exam was improving, and on hospital day 6, elected to perform an upper GI with the plan to see if she had any extravasation anywhere, again, because our working diagnosis at that time was that she'd had a perforated ulcer. So you can start to see here she's got just massive distension of her stomach. Some of these later images are a little bit better. Again, here her stomach outline just massively distended.
This is the upper GI now.
Yes,
we're
sir.
looking
So
at.
we got the contrast coming down into her stomach. We see it going through up here into her duodenum. We don't see any extravasation. Continued passage despite this distension. on down into her small bowel. So what we gleaned again from this upper GI that she had just massive gastric distension, but there was no extravasation. There was some ongoing pneumoperitoneum. But based on that, we elected to go ahead and start her on some SIPs and then advanced her on to some clears. Her antibiotics were stopped. And for all intents and purposes, she appeared to be improving at this time. So that was hospital.
That upper GI, again, was a gastrographin?
Yes, sir.
Okay.
On hospital day 8 now, so again, this is 2 days after her upper GI. She had been kind of intermittently tolerating some liquids. And so the CT scan we then repeated. So this is her third CT scan, if you're keeping count. She had, again, this fluid kind of in the area, which seemed to be sort of organizing and a little hyper-enhancing rim around it. Continues to have just massive gastric distension. You can see sort of some thickening of her gallbladder now, which again, all this is sort of in the same area of our presumed perforated ulcer. And we don't really see any pathology lower down in the abdomen. Again, this I think kind of gives you an even more impressive view of just the massive distension of her stomach. Again, at this time she's taking some clears and seems to be tolerating them well. They may just all be sitting right there, but again, this is a tough lady who every time you talk to her and she kind of knows what's on the line, assures you that she is improving, that she's doing just fine. And again, despite the fact that things did seem to go through on her upper GI, obviously her stomach again was still very distended, and so we elected to or offered the patient EGD, plan to kind of proceed with that to evaluate for the source of this obstruction, because on imaging it's very impressive. So on hospital day 10, she had her first EGD. The scope, we were unable to pass it really beyond or even into the antrum. It seemed to just sort of stop. It's in their scar tissue, it was sort of bent back on itself. It was just, you could not advance it. There were no mucosal abnormalities per se, but the stomach was just very distended. And so an NG tube was placed at that time under visualization, with plans to decompress her and see, how she did from that point. She had about 250 to 500 milliliters every 24 hours for the next couple of days. And this EGD, again, we repeated it on hospital day 13, so 3 days after that first one. At this time, our stomach was less dilated. Again, she'd been decompressed with an NG tube, but the scope was able to be advanced this time into the duodenum. Again, there were no mucosal abnormalities seen, and keep in mind our working diagnosis here was perforated ulcer. No evidence of an ulcer at that time, but the pylorus did seem to be narrowed. Given this improvement, we planned to let her try a full liquid diet, see if she was able to tolerate this. She sort of intermittently tolerated it. Several days later, hospital 16, she had her fourth CT scan. I've spared you the images of that, but just kind of in keeping with the previous one, she still had this residual sort of fluid collection around the inferior portion of her liver, and just some thickening, everything in the area. Again, her gallbladder had become progressively more thickened. The area of hepatic flexure of her colon seemed to be more thickened and was sort of adjacent to all of this. So just a lot of inflammation continuing in the area. So given that, and the fact that she'd sort of intermittently tolerated and not tolerated liquids and was still complaining of some bloating, we started to make preparations for the operating room. She had had a colonoscopy 5 years prior, which she said had been normal, but she had this thickening, and again, we'd had no mucosal abnormalities when we scoped her. And so to ensure that this wasn't something to do with her colon, we asked them to perform a colonoscopy. They were not able to get a complete prep, again, because of her inability to completely tolerate liquids. They were able to say that there was no frank or abnormality. There was some difficulty again seeing the right colon, but they didn't see anything obvious to account for the picture that we were seeing. And that was hospital day 17, now at this point. So we told the patient, made plans to, again, go to the operating room for exploratory laparotomy with the intention of probably bypassing this area, resecting the area where we presumed this ulcer was, and if we weren't able to do that, to bypass the area. So on hospital day 19, we went to the operating room, expecting to find perforated ulcer. When we were into her abdomen, again, as we saw on the CT scan, she had just sort of an inflamed, sort of sucked in mass in her right upper quadrant. And after some very tedious dissection, we were able to identify the gallbladder after we had sort of dissected off about half of it from the liver. And then ultimately we were able to identify the cecum, which was adhered up into all of this. And this was the appearance. This is the cecum right here, the terminal ileum coming in. And so these are some of the, where it was just adhesed and inflamed. What you don't see, what we didn't see and what I can promise you don't see here, is an appendix. And what I didn't mention before is that the patient did not have a history of an appendectomy. And so there should have been an appendix there, which left us with our new diagnosis, perforated appendicitis. And so what she had was the cecum had sort of flipped up anteriorly up to around her stomach and her duodenum. She'd had perforated appendicitis there that then resulted in inflammation around the area, fluid collection. She had an abscess that had developed sort of just under where this was stuck, that we were able to clean out, and this had essentially led to her gastric outlet obstruction. It was an extrinsically compressing on the stomach, and so once we were able to remove all of this, it became pretty obvious that her stomach, her duodenum appeared normal. We did put the endoscope back down into her stomach and her duodenum at the time of surgery. Again, there were no abnormalities. We were able to pass the scope easily and had relieved our extrinsic compression and our gastric outlet obstruction. So we were able to imbricate the appendiceal stump and then pec seed the cecum back down into the right lower quadrant, as it had obviously become quite mobile. So we went from an ulcer to perforated appendicitis. So just to review appendicitis in general, 7% lifetime risk, more common in younger ages, 10 to 14 in boys and 15 to 19 in girls. For the students, when you're looking at appendix, some features you can look for: an average length of about 9 centimeters, a transverse diameter. You'll find all kinds of numbers, but less than or equal to about 6 millimeters is sort of your upper limit of normal there. And what causes appendicitis? There's multiple different theories. Most commonly, we think about obstruction with a fecalith. Lymphoid hyperplasia is another one. More rarely, parasitic infections, and then neoplasm, certainly always a concern. Symptoms generally anorexia, followed by epigastric or periumbilical pain, and the classic kind of presentation is transitioning from epigastric umbilical pain down to the right lower quadrant. You may have some nausea and emesis. Generally, you see this appear after the pain. It's sort of the classical textbook definition. As you'll see when you're hearing your surgery rotation, patients certainly don't always follow the textbook. But that's, again, sort of the classical description. So the diagnosis certainly depends on your clinical presentation. You can get a lot of information from taking a good history from a patient and a good physical exam. Often our patients already have imaging when we see them. Generally, for us on the adult side, it's a CT scan where you're looking for it's just distended, a fluid-filled appendix. You may see some straining around it. You may see this appendicolith. And CT is quoted as having a sensitivity of about 94% and a specificity of 95%. Other modalities, if you spend any time with on the pediatric side, you'll see ultrasound used. And with that, you look for a distended appendix. You may see some hypervascularity in the wall of the appendix. And that has a sensitivity of 86%, specificity 81%. Remember that ultrasound certainly is user dependent, so if you've got a good tech doing it, maybe a little more reliable. And then MRI obviously is another option, which, if you have the opportunity to see a pregnant patient who we're concerned about having an appendicitis, you may be able to look at an MRI in that context. So the treatment for appendicitis, our treatment for appendicitis is an appendectomy. Some people might argue for antibiotics, but I will leave that for another date. So as far as we're concerned, our treatment is an appendectomy. And what about perforated appendicitis? So up to about 20% of adults will present with what's considered a complicated appendicitis, defined as their diffuse peritonitis, an abscess in the area, perforation with that, and the treatment depends on presentation. So our patient, did have focal peritonitis. She didn't have, hers obviously a little bit different, but these patients who present with just a contained fluid collection, who don't appear floridly septic and don't have just generalized peritonitis, you can make an argument to watch them with IV antibiotics, and then plus or minus having radiology place a drain if there's a drainable fluid collection that you're able to identify. However, even with the perforated appendix or complicated appendicitis, a patient with sepsis and generalized peritonitis should have surgery at that time. And then there's this question of an interval appendectomy, which, quite frankly, I did not realize was so much of a question because generally our practice here has been to perform an interval appendectomy. Until I did a little bit of research. So this particular paper, they looked at 18-year and older patients, so just adult patients with complicated appendicitis who did have an appendectomy within 1 year of their presentation. So they looked at 31,000 patients, and they divided them between early and late surgery. Early surgery was considered to be 48 hours from the time of admission, and that was the majority of them, so about 28,000 of those 31. And late surgery was 48 hours, or beyond 48 hours, whether it was an interval elective surgery or just a late surgery in that same admission. What they found was that the patients who underwent an early surgery were less likely to have complications at 1 year. They generally had a shorter length of stay, so 5 days versus 9 days for a later surgery, and you could make the argument, well, if they have later surgery, they're just prolonging it anyways. I think the argument here is that an earlier operation, they were able to go home sooner. They were less likely to be readmitted within 1 year if they had early surgery. They looked at then comparing the interval elective surgery, so this might be someone who you wait 6 weeks on and then come back and do, versus a late surgery during that admission beyond the 48-hour mark, and found that the interval appendectomies tended to have fewer complications and shorter length of stay and fewer readmissions. And so again, the argument being that you could operate within that 48 hours was better than waiting during that first admission. The non-operatively managed, they had some, and they felt like they were more likely to be readmitted within the year. They did find that they were more likely to be free of complications at 1 year, but their cumulative length of stay over the course of that year was greater. And so this certainly gives some argument for an early operation with patients with a complicated appendicitis. This paper out of Mississippi looked again at operative versus non-operative again in patients with complicated appendicitis, which is technically what our patient would have had. They found that with early surgery, again defined as less than 48 hours, they had shorter length of stay, they had less chance of readmission, and they only had 2 extended resections, so 2 patients that required resection beyond just an appendectomy. And you can kind of see over here that their study patients, they had complicated and uncomplicated. They had 247 patients that they looked at for this early surgery, so pretty good number. The patients who had no surgery was 58 out of their 611, and ultimately they were able to manage those 39 of those without surgery. So again, some argument here, but the point here is that early surgery did not lead to more complications, and that's sort of been the concern, is that if you operate on these patients too soon, that with all the inflammation that you might not be able to perform just an appendectomy, that they might end up with more surgery and more morbidity. And then there's this paper out of Baltimore. They looked at interval appendectomy or wait and see. So the reported rate of recurrent appendicitis is sort of all over the board after non-operative treatment, but anywhere from 6 to 20% was the best number that I could nail down. Your chances of recurrence are greatest in the first 6 months, and then after about 2 years, your chance drops pretty significantly. So they looked at and did a review of PubMed and the Cochrane databases and were able to come up with 1,400 patients who were treated non-operatively and compared those to 543 patients who were treated with an interval appendectomy. And what they found was that the rate of recurrence in these non-operative patients, they quoted as 12.4, so within that 6 to 20%. The morbidity they found to be 13.3%, which was higher than the morbidity of the interval appendectomy patients, a little bit lower at 10.4%. The length of stay for patients who were managed non-operatively was almost twice as long as those who had an interval appendectomy, until you accounted for the initial hospitalization plus their hospitalization for their surgery later on, which was about 14 days. And so what this paper sort of argues is that the risk is relatively low, and that with only 12% of theirs recurring, that perhaps you're operating on a lot of people that you might not need to. And finally, someone who just comes out and says it. This particular paper looked at 32,000 patients, and they just considered acute appendicitis. So that's sort of my caveat with this one, is that they didn't really delineate out complicated or perforated with an abscess versus non-complicated. But they looked at 1,000 patients who were treated initially non-operatively. 15% of those had an interval appendectomy, and 864, or 85% of those, did not have an interval appendectomy. They quoted their recurrence of those as just 5%, which was certainly on the low end of the numbers that I was able to find, had recurrence, and they looked up to 4 years. Half of those were able to get away with just an appendectomy, and then about a third of those they treated again non-operatively and said that in their study time they didn't have a recurrence after that, so they were treated, I guess, twice during that time. What they found was that there was no higher recurrence if you had an abscess or been treated with a drain compared to if you had just, I guess, uncomplicated appendicitis. So they didn't think that that made a difference, or their data showed that it didn't make a difference in the rate of recurrence.
Where was that paper from?
That one, I can't remember. I can't remember where that one was from. I'll have to look it up and see. What I found was there are papers all over the board. So you could find multiple papers to back up whatever you wanted, and there was a lot more debate. Cameron's just flat out said, like our textbook Cameron's just flat out said interval appendectomy was not warranted. And again, in my experience, it's been our practice here that we generally do perform them, and so what I found was that not everyone feels quite so strongly. So then we come back to this gastric outlet obstruction, which was how this whole thing started in our whole presentation. And so she was here for just under a month. She was discharged, I think, just the day before a month. 4 CT scans, 3 EGDs, including the one under operation, an upper GI, liquids, MPO, NG tubes, and ended up what our initial thought was not correct at all. So appendicitis and gastric outlet obstruction was not a presentation with which I was familiar. You can find several articles that talk about appendicitis causing an obstruction in patients with known malrotation. But in patients without this, I was able to find one paper. And this particular patient presented with a distal duodenal obstruction. And the picture is kind of hard to see, but so they've got the cecum here with the appendix coming off here, and then this structure coming down is the duodenum. And so they talk about in the paper or in their description about how this particular patient, the appendix, had essentially wrapped around the duodenum, causing an obstruction. It was a 34-year-old male who was otherwise healthy and just had a week of pain. This patient had a leukocytosis, hadn't had any other significant weight loss, changes in bowel habits, and their findings, they were distended stomach and kind of compression of the beyond this first part of the duodenum, so sort of similar to ours. And what they quoted in this paper, this was from 2002, so it's been 16 years, and at that time they said that there was no other reporting in the American literature of acute appendicitis causing duodenal obstruction in a patient who did not have malrotation. And I searched every which way and every phrase I could think of and couldn't find. This was the only paper that I could find kind of clearly delineating this, which thus made it an interesting case. So cost of medicine, so I tried to get cost of the processing the scopes for an EGD because our patient had 3 of them. What I found was that is apparently bundled in and you can't get that. But other than her extensive hospital stay and CT scans and the upper GI, which certainly gave costs, I looked at some of the tools that we use every day in the OR that you might not think about. You drop a pack of suture on the floor, or you ask for another one that you don't use. It's not astronomical, but about $10 a pack for these number 1 Vicryls that we use to close, and $1.21 a pack for the 2 silk. So again, not astronomical, but certainly something. And just if you're curious, the ET tubes that we'd throw around are about $7 a piece, and that's cost to the hospital. So these are my sources. That's your Halloween treat.
Questions, comments? Yeah, Dr. Parker.
Yeah. In some of the literature now and at some of the meetings, we are being sort of herded towards counseling patients about appendicitis when they present initially with acute appendicitis. And we are encouraged to offer those patients medical treatment for their appendicitis and not surgical treatment. As surgeons, we're supposed to do that. I don't think I've ever done that. I think I say you have appendicitis, and it's pretty simple now to take these out laparoscopically. But the literature is getting replete with this business about counseling patients for non-operative treatment of their appendicitis, and they're supposed to help with the decision-making. How do you counsel a patient now about non-operative treatment of initial presentation of acute appendicitis? What do we tell those folks?
So despite what I read, which again was all over the place, it hasn't really changed my opinion that appendectomy is a good operation. It's a relatively easy operation, and even last week, Dr. Hunt and I operated on a patient who had perforated appendicitis that maybe you could have made an argument she didn't look awful, had been going on for several days, could have made the argument, we'll treat you with antibiotics, but we were able to operate on her, got it done pretty quickly, and she was better and went home the next day. And so it's sort of hard for me to argue against something that, we don't want to call it a quick fix, but you operate, they get better, and they go home. And our particular patient here, a lot of you probably rounded on her and saw her after surgery when she had a little bit of delay in recovery, just return in bowel function, but she did better and she went home. This wasn't something that just progressed on and then took, more weeks to months to resolve, which I think it, and Dr. Smith and I talked about that at the time of operation. If we hadn't done anything, what would have happened? And our feeling was that eventually over weeks and months she would have gotten better. But, it's hard for me to justify not just doing an operation that fixes the problem.
Dr. Mejia.
Yeah, well, there's actually a big trial going on right now that they're looking at that, and they're doing antibiotics, even sending the patients home with pure antibiotics with early appendicitis. And I don't think until we see that trial, I don't think I'll do it. There's also a question of malignancy, and that's one of the reasons why we do it. In Europe, as we talked yesterday, and that's what probably Bob was asking where that paper was from. Yeah. In Europe, they don't do the delay appendectomy. They just treat it with antibiotics, and they don't do it. But there's always that question of malignancy, and I don't know on the papers that you saw how many of those have malignancies that were found later.
Yeah,
so
none of them address that, and like we talked about last night, I mean,
yeah.
They all kind of gave you the caveat of there's this concern of inflammatory bowel disease or malignancy, and so at the very least we're recommending, a follow-up colonoscopy and or CT scan to follow it. But again, then you're just following them with more things as opposed to just operating and fixing the problem. I guess it's sort of...
The last question that I have, the last endoscopy that you were able to pass the scope and pass a feeding tube, you guys think about doing an endoscopic ultrasound? Because if you already waited that long and you don't know if you have a malignancy there, it would have been good to do the endoscopic ultrasound, make sure that you don't have a malignancy that, because in this gastric cullet obstructions, there's always a potential of malignancy. Right. And what is the standard treatment for gastric cullet obstruction?
So we didn't, there was not talk of of ultrasound at that time. And again, I guess because there were no mucosal abnormalities, then it was sort of, I guess, perplexing at that point.
Good thought to it, but at least considered it, yeah. Brief question.
So, I mean, the whole conversation about non-operative treatment of appendicitis doesn't apply here to this case because you all didn't know what was wrong with her. So, that doesn't really apply to her. So when you look back now at the scans, can you pick it out? I mean, can you see the pathology now?
So when I look back, I mean, there's an area on the first one that I can say, maybe that's where the appendix was, and
I mean, is this, you see
and
the
it was-
cecum overlying the gastric
The
outlet
overlying- I
on the
think-
scans? I can't remember.
yeah, I mean, it's sitting up there.
Was
I
this
think it's hard
retrocecal
to-
or was this was this was
Her
a
cecum was just sort of flipped
this
up
was
and
a
over a
cecal
little bit.
bascule type change?
Yeah, sort of like that,
Okay,
I guess.
all right.
Because the question is whether, I mean, because one of the questions is whether, can you learn anything from all the imaging? I mean, did you miss something? Did everybody miss something, or was it just not particularly visible?
I think what I would take from it is not taking for granted that just because she's got the air around that area, their pain was up there, that, oh, it's just an ulcer, because that's,
Right.
the
But
common thing.
Because, I mean, I think it's pretty remarkable that you all did 3 CT scans and you really didn't, I mean, a perforated duodenal ulcer, usually you'll see something there in the way of an inflammatory mass, or you'll see something. All you saw was the stuff around the liver. And so that, it never really showed up locally, which really should have called into question that diagnosis, because you generally will see something
I mean, she had
instead
some-
of nothing in the
Right.
area.
She had some progressive thickening of everything in the area, but I think, again, that was just
That was up around
reactive to what was
that was
going
around the
on in
liver and the gallbladder.
hindsight.
That was the
Yeah.
result of the perforation. So, okay, that's interesting.
We're so close on time. Wait a minute, don't leave. We're going to save your case, Bobby, for another, because I don't want to short sheet you here. So any other teaching points that people want to make, let's make, because I've got several here, but go ahead, Bob.
I just think the literature's all over the place on this. This trend started in Europe, and I guess they're continuing to hammer away on it. As far as what I counsel the patient, I counsel them they need to have their appendix out when they have appendicitis. Every one of these that I've been talked into managing non-operatively is smoldered along. The last one
That's
I
still,
did.
let's make it clear that, so that, if you have to decide one way or the other, guys, surgery residents, medical students need to know this too, going into primary care. The standard of care right now is to operate.
Yes, I would say
That's
in
still
the
the
United
standard of care.
States.
Now, you can make an argument to not operate, but you're going to have a hard time making that argument, a harder time making that argument. Now, I think, but I wasn't aware that somebody's really started a study, and, somebody had to do this because the literature, as everybody has indicated, is all over the place about what to do. And, I mean, it's almost like pharmaceutical companies involved in what's great here. But, I mean, boots on the ground, appendicitis still can kill you. If you want to go back and look up a paper that was published in the early 80s that came from this institution about appendicitis in people older than 50, which this is, because you're
75.
referencing over than 18. And if you look at it, if you look at appendicitis and the pathophysiology of appendicitis by decade of life, then actually starts to get worse at 40, it really gets worse at 50. And so there are people who die from appendicitis, especially when they're 75, which she was. And so, it goes back to, rather than being more conservative or non-operative treatment in older patients, you still need to consider being maybe more aggressive. It's a wonder this lady, I mean, you first of all, the cost of this, I'll bet her hospital bill's $500,000. By the time it's all said and done. But, I mean, that's not a reason to do anything. But it sure does show you that appendicitis can mimic everything. And so when you have an abdominal situation and you're saying, what's wrong with the patient? Two things to think about, TB and appendicitis. Always, because it can mimic. Now, for the students in particular, go back to what she talked about in terms of what causes appendicitis. Number one, you have to know the anatomy of the cecum and the appendix, because it can be lots of different places. It's much like the blood supply to the gallbladder or the ductal system of the gallbladder. It's one of those things. Think back to anatomy and then think about the physiology, and you think about where the appendix is. And if you're talking about a cecal bascule with it flipped up anteriorly, then appendicitis could do just this, subhepatic abscess. Bigger and much more frequently encountered is retrocecal appendix. That one's really tough, and it also has an insidious onset, presents differently. CT scans and so forth not always as helpful. So just be aware that if you have a patient like this, you're going on, you can't figure out what's going on, especially with all of our studies like EGD and everything now. Think about appendicitis. And I mean, I'm saying this, and I've overlooked it several times myself in a patient like this. So, Bob, you want?
Yeah, I just, anecdotally, I have not been happy doing it. Most of the time, you can go in laparoscopically and dig the phlegmon out, find the appendix, and do an appendectomy. And the teaching point I would like to make is it is not a crime to open somebody up and
Absolutely.
clean it out and be done with it. Now, that being said, I have had 2 cases now where I have gone in and I never found the appendix. And you just find some, just really deteriorated tissue and you remove it. But as long as you can find the attachment point, base of the appendix, and oversew that on the cecum or get some kind of repair done where the appendix used to attach, should be fine. Put a drain.
Well, but I would assume in those patients that they have some sort of history somewhere along in their lives that would make you think they probably had appendicitis.
Yes.
I
Oh,
mean,
yeah.
They
Yeah.
all had. But I mean, and again, think about the pathophysiology. If an abscess forms, gangrene occurs, and you heal from it, then it's gone, right? And so, it's entirely possible that you wouldn't have an appendix, that it
Right.
essentially burned itself up when
They both had
you had to.
presented during their initial bout of appendicitis, but they had both avoided medical attention for over 5 days.
Yeah.
Yeah, Bob, to your point, I usually say to the young surgeons, you can't just make the diagnosis of appendicitis, period. You have to classify it further before you make a decision, even of that nature. There are mild appendicitis, barely a diagnosis of exclusion. Even if you remove those, you almost have to wait for the pathologist to tell you there was some lymphocytic infiltrate, therefore qualifies for appendicitis. In the old days, we used to do appendectomies, Dr. Burns, for chronic appendicitis. And that was a procedure that was commonly done in the old days for people persistent right lower
These are
quadrant
still
pain.
the old days then. These are still the old days because you still have that sometimes.
Well, I'm saying, but that was a common
Yeah.
scheduled
Okay.
procedure. Anyway, but just always getting into your mind, the idea, is this a simple, uncomplicated, mild, early appendicitis that you can barely even see in a diagnosis, or is this a gangrenous, otherwise complicated appendicitis? So that helps you in the decision-making process. I agree. I think, I don't know who will offer conservative management here right now. I think we can discuss it in a very mild, early case. I can even see it on imaging. But
Well, you go back to 2 weeks ago, the discussion we had. She described a patient with peritonitis. Generally speaking, you operate on appendicitis. Peritonitis for some reason or other, like you say. Now I'm going to put Dr. Murray on the spot a little bit, so give him the microphone and let me make a point. This patient, he just came to us from Albany, Georgia, where he was in practice by himself with other people to work with. The management of a patient like this non-operatively versus operatively in an institution like this or where you came from. Because in his case, he's got to go operate electively, be on emergency room call, and go to the office. So how often can you go by and see this patient? This one that you're describing here, you had either a resident, a medical student, a faculty 24/7 in-house. You could go by and see this patient every hour or two, which frankly, if I'm going to follow a patient like this, I want somebody doing that. Dr. Moore, you agree? I mean, you have that luxury, if you will. What about in a situation like we're describing where you're in Albany, Georgia.
I think you make a great point, Dr. Burns, that don't have the luxury for serial exams to the extent that we want to in private practice. But I think a consideration for the surgical residents is, from a medical legal standpoint, your defensible ground is much more secure on the I operated for this basis than I chose not to operate. So whole terminology for conservative management is kind of a misnomer, as you alluded to earlier.
That's right.
That the conservative ground is to operate.
Thank you. That's a perfect point.
And so I think that, my colleagues who were sued, even though that's not the first and foremost reason for it, but my colleagues that were sued in the past, was their decision not to operate, and pathophysiology progressed predictably. And I think that sticking a scope in somebody is a very low risk, potentially high benefit endeavor, particularly with laparoscopy. The insult to the patient is very minimal. And if you go in there and you find a perforated ulcer that's got a gram patch, a physiologic gram patch stuck to it from the omentum, you might choose not to to persist with non-operative management, but I would suggest that you would find this if you stuck a scope in early in the endeavor, and particularly whenever your second CT prior to the third shows some free fluid. I think free fluid is a predictor of poor outcome in the non-operative realm.
Yeah, good point. But also the point that he made too is that you don't have the luxury of somebody who really does feel of peritonitis frequently, seeing this patient often, and so you have to do that. But he also, thank you for picking up on my point, this was liberal management as opposed to conservative management. Non-operative management is more liberal, even though we refer to it as conservative. It really is not. So any other questions or comments or points people want to make? This is a great case, but exemplifies a lot of teaching points. But again, if you go back and look at it, if you operated on her earlier, yes, you had a patient that had some COPD and so forth, but she still had it when you operated on her.
Consequently, she tolerated her
She
operation
still
very
had
well.
it at 30 days into the case, right? So you weren't going to change that. Now, if you could optimize her by 24 hours of inhalants and whatever, great, but you're not going to change that. Nor cardiac situations, I don't think. Well, it's a great case, well presented. Thank you very much. Bobby, we'll have your case on another time, okay? Thank you very much.